Hello, this is Joan Meekins, a CCG cancer lead. This is an introduction to the 2-week wait suspected skin cancer referral form. This presentation will take you through the new referral pathway and also show you how to fill the form in. Unfortunately, there's been a problem with the referral form shown in the presentation. However, a new version has been created that looks slightly different, but the content and the information requested is exactly the same as in the form demonstrated. Hello, this is Joan Meekins, the CCG cancer lead for the Vale of York. I'd like to tell you about a new pathway that's been developed for the management of 2-week wait skin cancer referrals. This is being phased in April 2016. I just want to talk you through the form so you're able to use it more efficiently. 2-week wait skin cancer referrals will be sent to the RSS, Referral Support System service, which is managed by the CCG. These referrals will be triaged by a team of consultant dermatologists, and the team will give an opinion within 48 hours of the referral being sent to them. Like the other proformas, this skin proforma starts with a suspected skin cancer title at the top. The button shows you where the referral will be sent to. This will be to the RSS. This referral will be sent electronically. Faxed referrals will be phased out. On the left-hand side of the form here, you will see all the patient details, and please make sure you get the correct telephone number, both landline and mobile number for the patient. On the right-hand side here, you'll get the information for the GP and the GP practice. These proformas should be filled automatically from EMIS and System 1 systems. At the top of the form here, you'll also see a hyperlink to suspected skin cancer guidance. I'm going to tell you what's on that guidance, and also a link to special sites which will tell you which sites do not get referred on this form, and also how to refer basal cell carcinomas. This skin guidance gives information about which patients should be referred on this 2-week wait referral form and which patients should be referred routinely. If you see on the left hand side, melanomas, squamous cell carcinomas should be referred on fast track. Basal cell carcinomas, Bowens and AKs should be referred routinely. If you look down here, there's information about what these look like and how to treat them on the RSS guidance. If you click on the hyperlink, it will take you straight to them, give you very useful information. Back to the left hand side of the form, if the lesion you are worried about is on one of the special sites, which you'll see down here, which are the vermilion under the lip, the anus, the penis or the vulva, these lesions should be referred on different fast track forms. On the, say, the anus one, there is a space on the suspected colorectal cancer referral form for referring this lesion up on that form. And the same with the vulva, that will go on the gynae form, the penis will go on the urology form, and the vermilion of the lip will go on the maxillofacial form. For each of these, there's a hyperlink which takes you straight to that form. If the lesion is not on any of those special sites, then the form I'm going to describe later on is the one you should be using for this referral. This slide gives information about features of melanomas and squamous cell carcinomas. The information on this form is exactly mirrored by information we're asking you to fill in later on the proforma. You'll note that NICE has brought in a 7-point weighted checklist for melanomas, and a score of greater or equal to 3 should trigger a 2-week wait referral pathway. This slide just shows an example of what the RSS guidelines look like. They're updated regularly by our GPs with special interest in dermatology and our consultant team. These forms are well worth reading and familiarising yourself with. They give advice about what treatments can be given. Please note also that you might be given permission to actually biopsy some of the lesions when they've been triaged by the consultants, and some practices do offer this service. This is just to show you again where you the hyperlink, where you would find the hyperlink to the suspected skin cancer guidance, and it's along at the top here. As a standard part of all the suspected cancer proformas, we're going to ask you to confirm with the patient that they understand parts of their referral. There are 3 standard statements we'd like you to confirm. The first one is to confirm that the patient understands they've been referred on a suspected cancer pathway. Research has shown that if we give patients small amounts of bad news over a length of time, they'll be able to accept the outcome with less anxiety. The second part of the statement here is that you have given the patient the information leaflet, which explains to them what will happen next, and also how they will be contacted to be given an appointment. The hyperlink opens up and it will take you to the correct form to be used for each proforma. This is the skin patient leaflet. Please note it is telling the patient that they're being referred for an opinion with a specialist, and this opinion, the specialist will then decide whether they will be seen as a 2-week wait, routinely or urgently. Patients may also be returned to be dealt with and treated in primary care. The leaflet can be used to reinforce what you've told them in the consultation. The third statement we're asking you to confirm is that the patient is able to attend for an appointment within 2 weeks if that is what has been determined by the consultants who have triaged the referral. It's important the patient understands they might need to be seen to either diagnose or exclude cancer. They should be encouraged to come within that 2-week wait. If they have another commitment, such as a holiday or a work commitment, you will need to discuss the implications with them for not attending the 2-week wait appointment when it's been offered. One of the consequences may be that the patient's holiday insurance will be invalidated if they decide to travel, but they've already been advised they've been referred for a 2-week wait opinion. We'd also like to advise you not to downgrade a 2-week wait referral to urgent if a patient cannot attend within the 2 weeks. This has been done in the past so that the 2-week wait patients do not breach the targets set for the hospital. If the patient has the criteria set for a 2-week wait referral, they should be referred as this. There are some breaches that occur for the 2-week wait targets, but the hospital does have leeway for this. However, if after discussion the patient decides to not attend or make themselves available for this 2-week wait, please let the RSS service know in this box here when the patient will be available to attend. This is very useful for the RSS staff, as they will try and contact the patient by letter rather than by telephone. This next part of the form is where we are going to ask you to mark the position of the lesion that you're referring up for an opinion about. Don't worry too much about getting a completely accurate position, as you're going to be sending a photograph to also show this position. Around the eyes might be the most difficult area. The consultants will use this diagram and also the photographs in combination to decide the triage of these lesions. The site of the lesion will dictate which speciality the referral is sent to. This will be decided by the triaging consultant. For example, lesions around the eyelids will be triaged to ophthalmology. Lesions on the face, some of them will go to maxillofacial. Some lesions below the clavicle will go to plastic surgery. As a GP, you will not need to get involved with these pathways for the triage. It's a triaging consultant who will sort this out. We hope this will mean a great improvement to the service, as GPs will not need to worry about where to send the lesions to, and each patient will see the correct specialist. At the bottom of the form you will see there's an area which asks you to perform a full skin survey of the patient. This is good practice to check for other lesions, especially in looking at the back on elderly patients. It has been agreed that if a patient is seen by the dermatology team, they will perform this skin survey. However, if a patient is seen by the maxillofacial or ophthalmology team, then a full skin survey will not be carried out. These teams will inform the referring GP that they have not performed a skin survey. There might be a later date or a later opportunity when you might want to have a quick look at other areas of the skin on patients who've been referred up. This slide is just to remind you that BCCs and also lesions at the special sites should not be referred using this suspected skin cancer form. There's another hyperlink to the suspected skin cancer guidance that I've already talked you through. This part of the form is to help you describe the lesion. If there's more than one of the lesion, then there's a space below this where you can describe the second lesion. It's really helpful for the consultants to know the size of the lesion, also the appearance. The history of how long the lesion has been present for is also very important, and how quickly it is growing. Additional information, if the patient is immunosuppressed or has had previous skin cancer, is also very important. This form will ask you to try and give an idea of what you think the diagnosis might be, but we understand that a lot of the time it can be very difficult. A photograph should be attached to this referral. A guidance about how to take a photograph and whether it's taken on a camera or telephone is given in this link. Please note there's governance issues if you choose to take a photograph on your own telephone. We realise it will take some time for practice to set up a system for taking and sending photographs. The dermatologists have already found that photos that are sent with routine referrals have greatly helped them to make sure the patient is seen and treated in the correct timescale. A photograph is now regarded as a key part of information needed for a referral. After 3 months, photographs will be expected to be part of these 2-week wait referrals. Some practice may be able to take dermoscopic pictures, and this will be fantastic. This shows you the 2-week wait skin process, from the patient being seen at a consultation, submission of the form to RSS. Administration staff at the RSS will check the form to make sure it's complete and a photograph is attached. The consultants then triage the form. The decision is made about the appropriate next step, whether the patient needs to be seen or can return to primary care. And then emails are sent out from the RSS software to let both you and the patient know what's going to happen next. If the consultant has triaged the referral and find that a hospital appointment is needed, they will forward the case for booking by the RSS admin staff, and the booking teams will contact the patient and let them know what's going to happen. Please note that some of the patients will not need to be seen on 2-week wait appointments and will be seen in a routine, more timely way. The patients should be made aware that they might not be seen within 2 weeks, and they might need to be seen within 6 or even 8 weeks. If the case has been triaged by the consultants and it can be managed in primary care, or any additional information is needed, they will let the referring GP know, and this will be the returning function on ICG will be used, and I'm sure you're used to this at the moment. The practice will then need to contact the patient if they're going to be managed in primary care.